Topic for today's seminar is Stage 2 Surgery and Implant Impression. So these are the content under which I am discussing the topic today. So coming to the introduction, so once the implant is osseointegrated, we need to make the impression of the implant to guess the accuracy, to guess the position, angulation of the implant. Now to make the impression of the implant, there should be some connection between the implant fixture to the oral cavity so that we can attach an impression coping and we can make the impression. So, in the modern dentistry, almost every prosthetic restoration is dependent upon a model. This model is the link between the dental practice and the dental laboratory. If the link includes any error, it may trigger a chain of reaction that involves undesired effects. So, the most important step for an accurate impression requires a precise registration of the implant position and the precise registration of the gingival situation. So, criteria which is given by Hertel et al., in which they have mentioned that it depend upon for the second stage surgery, it depend upon the width of the fixed mucosa. It depend upon the keratinization thickness of the mucosa, whether to go for the excisional technique for second stage or whether to go for incisional technique. So, when the mucosal thickness is more than 4 mm, when the mucosal thickness is more than 4 mm, we should always go for excisional technique. As there is adequate amount of fixed mucosa there, we can go for excisional technique. Whereas when the fixed mucosal thickness is less than 4 mm, the incisional technique is followed. So when the mucosa thickness is too less, the free gingival graft is carried out first, followed by second stage surgery. So the second stage surgery, the incisional technique, there are Benhart minimal invasive technique, keyhole expansion technique, soft tissue punching technique, and the laser trimming technique. Now the author has told that this laser trimming technique and soft tissue technique are the less invasive procedure and which should be followed out. But there are in some conditions we have to follow the keyhole expansion and Benhart minimal invasive technique. Now in this Benhart minimal invasive technique, what we do, we generally use an aerator burr to trim the tissue over the implant orifices. Once the implant is exposed, we just load the implant with the temporary crowns, and once the collar is formed, we make the impression for the final crown. Now, second is the keyhole expansion technique. The keyhole expansion technique, we open the orifice of the implant, we remove cover screw, and we place an gum extractor. Now, this gum expansion will create a gap so that we can place an healing abutment over the implant. And once the tissue collar is formed, we'll make an impression for the final crown. Now, next technique is the incisional technique without tissue transfer. Now, in this technique, what we generally do, with the help of the guiding stent, with the help of the stent, we make we mark the implant orifices. After marking the implant orifices, we make a plus shape or diagonal shape incision over the implant crest. Now, after making the incision, the implant flap is little swickered and the cover screw is removed and healing abutment is placed. Once the healing abutment is placed, the implant is left for 15 days. Once the collar is formed, the impression is being made. Now, the second technique being the incisional technique with the tissue transfer. Now, suppose when the width of the keratinized mucosa is less, or to increase the bulk of the keratinized mucosa in the aesthetic zone, we need to follow this tissue transfer technique. Now, here, the first technique for increasing the keratinized mucosa thickness is the rotated palatal strap technique. Now, here, what we do, we give incision which is little palatal by sparing the papilla. Now, after giving the palatal incision, the flap is reflected and rolled on the buccal side. Now, this flap is tightly, the cover screw is removed and the healing abutment is placed on the implant, and this flap is tightly sutured around the healing abutment so that a proper collar should be formed and there should be a development of the interdental papilla. So the next technique for increasing the bulk of soft tissue in the buccal aspect is buccal pouch technique. Now here what we do, we give a U-shaped incision over the implant head, and this semilinear flap is rotated on the buccal side and sutured. So this will lead to increase in the thickness of the buccal mucosa on the buccal side. Third technique is given by Mish, that is split finger technique. After giving a U-shaped incision, the U-shape of papilla is cut into two parts, two fingers, which is attached to the either side of the papilla, that is mesial and the distal side of papilla, so that there will be increase in the soft tissue contour, there will be development of papilla. And the third is the and the fourth is compromise situation, where there is no adequate soft tissue, so gingival soft tissue augmentation should be carried out for that. So coming to the implant component, which will be requiring after second stage surgery, that is the perimucosal extension. Now, it is also called as healing abutment. Before placing an healing abutment, a cover screw should be removed from the implant. Once the cover screw is removed, the healing abutment can be placed. Now, this healing abutment comes in the different dimension and different heights. Now, suppose if we are replacing the posterior molars, we'll be needing a wider diameter healing abutment. Suppose the thickness of the mucosa is more than 4 mm, we need to take the healing abutment of size 5 mm. The healing abutment should come 1 mm above the gingival surface. Next is the transfer abutment. Now, these are the abutment which will be torquing in the patient's mouth to receive the final crown. It can be straight, it can be angled, it can be multi-unit abutment. So coming to the impression coping, now there are various type of coping available for the different company, different design impression coping are available. Again, the material which is used to make for impression coping are very different. So starting with the first, which we regularly use in our college, that is transfer and pickup impression coping by Austin. So the transfer impression coping, these are tapering. As the name suggests, we need to transfer this coping from the patient's mouth to the impression. So before making the impression, this transfer coping we are fixing in the patient's mouth will make a putty light body impression. After removing the impression, we need to transfer this transfer coping from the patient's mouth to the impression. As they have indentation, the transfer impression coping will properly lock into the impression material. Second, we have pickup impression coping. Again, as the name suggests, we are picking this impression coping with the impression. So an impression coping first attached to the implant, a hole is created in the plastic tray. From this, a guiding screw is loosened and the impression is removed with the pickup impression coping. Now, second is the square type of impression coping. Now, these square coping are generally used with the abutment level impression. Now, after torquing the abutment of the implant surface, this square impression coping is attached to the abutment with the help of the guide pin. Now, after making the impression, this is similar to that of pickup impression coping. This guide pin is used to loosen this square impression coping, and the coping will come with the impression, and the abutment is transferred to the impression before the impression is poured. Now, second is the tapered impression coping. This is like a transfer impression coping. It is attached to the superior part of the abutment and the impression is being made. Now, the entire assembly with the analog is transferred to the impression and the impression is poured. Now, coming to the snap fit and snap on transfer impression coping. Now, snap fit impression coping, these are the coping which we can directly snap. We can directly snap on the implant orifices and it will engage the implant orifices. So there are many studies on the snap fit impression coping accuracy. Many of the articles concluded that the accuracy of these impression coping are less when compared to that of open tray and closed pickup and transfer impression coping. Whereas snap-on transfer coping we can attach on the implant surface in the direct or indirect impression abutment level impression technique. And coming to the lab analog, now once the impression is being made, before attaching the transfer impression coping to the impression, we need to tighten this lab analog to the impression coping, and we need to reorient the transfer coping into the impression. Now, coming to the implant impression, why should you make an implant impression? Now, the implant impression is made to assess the position to assess the position of the implant, depth of the implant, axis of the implant, that is mesolingual, labiolingual, and the soft tissue contour. Now, coming to the material required for implant impression making. What are the requirements for implant impression material and which material we should use? The greatest accuracy occur if the impression is poured soon after as they remove. Polyether absorbs water, so not to be stored in this medium. Also, the addition silicones are very stable. The disadvantage with the polysulfide is that it shrinks drastically within 24 hours, and the condensation silicone has byproducts. So these two materials are not used as an implant impression material. So the least amount of dimensional changes which can occur in addition silicone and polyether can be used as a final impression material. 60% of the deformation occur when the elastomeric impression is removed from 1 mm undercut in height and depth. So when there is an undercut present, or suppose when we say there are two non-parallel abutments, there will be presence of undercut between the impression coping. So in this case, either we should go for an open tray impression technique, or we should use a more resilient, that is polyvinyl siloxane impression material instead of polyether impression material. Polyether impression material show more permanent deformation when compared to that of polyether. So how to make an implant impression for implant prosthesis? So basically these are divided into two categories. The first is implant level impression and the second is abutment level impression. Now implant level impression, we have two categories, that is pickup impression and transfer impression. Now pickup impression is also called as open tray technique and transfer is closed tray technique. Whereas the abutment level impression, first is direct technique and second is indirect technique. Now in direct technique, what we do, we generally at the abutment level impression, in direct technique, we use preparable abutment. Now, this preparable abutment is torqued onto the implant surface, and the abutment is trimmed. Abutment is prepared intraorally like in tooth preparation. Once the preparation is done, we make the impression and we transfer the record and this abutment onto the cast, and the crown is fabricated. Now coming to a video which will demonstrate the indirect pickup and closed tray technique. So once the implant is osteo-integrated, the screw is removed from the fixture and the healing abutment is placed. There are criteria for selection of healing abutment. Suppose the thickness of mucosa is more, so we need to go for an higher or taller healing abutment. There are various sizes available in terms of height and in terms of diameter. So depend upon the tooth, we can select the healing abutment and we can torque on the implant surface. We can place on the implant surface. Once the healing abutment is placed, the reflected mucosa should be sutured onto the healing abutment, around the healing abutment, so that a proper gingival collar should form. Once the gingival collar is formed, the suture is removed and the healing abutment is removed. Now, depend upon the technique which we want to follow, we can make the impression at this position. Now, coming to the transfer abutment procedure, that is when we are torquing the transfer abutment on the implant surface and making the impression. Now, in this technique, what we do, we just torque the implant abutment and take a radiograph whether the abutment is seated properly or not. Now, after placing the abutment is torqued to the implant surface and the plastic rigid coping is attached to the implant. After torquing the transfer abutment, a plastic rigid impression coping is attached to the implant abutment and the light body is spread around the impression coping. Now, a medium body or high body impression material is used to make a pickup impression, and the impression is made. Now, the plastic transfer coping will be there inside the impression. So this transfer abutment, either we can use a transfer abutment or the impression is poured directly. This transfer abutment, instead of using a transfer abutment or duplicate transfer abutment, can be used and these are attached to the lab analog and the impression is poured. Now, over this impression, after milling of this transfer abutment, a wax pattern is prepared. The crown is fabricated onto the cast. Now, next coming to the transfer impression coping. So this transfer impression coping is attached to the implant surface. After removing of the healing abutment, this impression coping is attached onto the implant orifices. Now this has particular indentation. It has particular marks, so this will go in the proper indentation which is created. So it is easy to place this transfer impression coping again inside the tray. So it has proper indentation come on the impression. So this we can reorient into the impression properly. After attaching to the lab analog, these are inserted into the impression and the impression is poured. Now coming to the open tray technique. Now in this open tray technique, Either we can splint both of these impression coping, or if the implant number is less than 3, the article or the review says that if the implant number are less than 3, we can directly go ahead with without splinting of this impression coping. If the implant number is more, we can either splint the implant and then make the impression. Now, once the implant is splinted, the impression can be made, and with the help, the cast can be put and the crown can be delivered. Now, coming to the accuracy of different impression technique for implant with internal connection. So, in this technique, a master cast with the two internal connection implant analog angulated at 10 degrees from each other were used. So, in this technique, 4 impression coping were used, that is octagonal transfer impression coping, non-octagonal transfer impression coping, non-octagonal pickup impression coping, and non-octagonal pickup impression coping with autopolymerizing resin splint. So here, the author concluded that the casts produced from the non-octagonal pickup impression coping were more accurate than those produced with the transfer impression coping. However, they said that there was no statistically significant difference in the accuracy between the unsplinted and splinted implant. Here in the study, there are only 2 implant placed in the mandibular anterior region model, and the study shows that there is no difference between the splinted and non-splinted implant. Now, coming to the next article, which compared the dimensional accuracy between open tray and closed tray technique at the 15-degree implant. Now, the purpose of this study was to compare 2 kinds of implant impression, that is open tray and closed tray, on 15-degree angled implant. So, the result of this study showed that the obtained result indicate the closed tray technique was significantly better in terms of dimensional accuracy when compared to that of open tray. Now, the result which we found in this study is entirely opposite the article which I have seen. In many of the articles, they have told the open tray impression coping is better. In the discussion, when I read, the author has specified the reason regarding the betterness of this technique. They told that they have used a custom tray for making closed tray technique for making the impression. They have used a custom tray, and also the experience of the operator is also matter while making the impression. So the study concluded that the closed tray technique is better in terms of accuracy. So next, coming to the accuracy of digital impression versus conventional impression for 2 implant and in vitro study evaluating the effect of implant angulation. So the objective of this study was to evaluate the accuracy of digital impression by intraoral scanner system in comparison to that of conventional impression. So the result of this study concluded that digital impression to provide a more accurate outcome in terms of trueness, precision, and angular deviation, while there is significant difference when the comparison is made in the linear deviation. So when we are comparing the digital impression with the conventional impression, the advantage of digital impression is there is precise and accurate angular deviation, whereas the advantage of conventional technique, here there is a precise recording of linear. The distance between the 2 implant can be precisely recorded in the conventional impression technique, whereas the angulation can be precisely recorded in terms of digital impression. And they show that non-splinted implant shows significantly inferior accuracy when compared to that of splinted implant. Now, coming to the dimensional accuracy of 2 materials, that is polyether and polyvinyl siloxane in direct implant impression technique. So in this technique, the 8 implant were placed in the lower model, the mandibular model, and the open tray technique was used to make the impression. The result of this study concluded that the difference in the distortion value between polyether and polyvinyl siloxane materials were not statistically significant. Similarly, the difference between splinted and non-splinted group among VPS and PVS material were not statistically significant. Now, coming to a study by Sangjek et al. In this study, the author has used different material to splint the implant. He has used the pattern resin, the impression plaster, and a bite registration material to splint the implant. This study concluded that the splinted impression coping with resin following compensation of the shrinkage and impression plaster had enhanced the accuracy of the master cast when compared to that of splinted with the bite registration material. Next study by Lee et al. Conducted to check the effect of subgingival depth of implant placement and the dimensional accuracy of different consistency of PVS and polyether material. So in this study, they have concluded that putty light body combined with polyvinyl siloxane impression were more dimensionally stable when compared to that of medium body polyether impression material. Vojdani et al. Conducted a study comparing three impression material, that is polyvinyl siloxane, polyether, and the newly developed vinyl polysiloxane ether. So on parallel and non-parallel implant with angulation up to 30 degree. In this study, he observed that the choice of impression material among the three mentioned did not affect the dimensional accuracy of the impression in case of parallel implant. But in case of non-parallel implant, polyvinyl siloxane exhibited greater dimensional accuracy of the impression than when compared with the polyether and vinyl siloxane ether. So the material must be accurate to reproduce the exact location of the implant. The material should have adequate viscosity, and it should not distort the soft tissue contour. And the material should be stiff enough to retain the implant and abutment analog. So the heavy body like material provide a necessary stiffness, and the light body material provide accurate reproduction of the detail. So coming to the impression making procedure for the completely edentulous patient. Now once the implant is osseointegrated, the cover screw is replaced with the healing abutment. Now once the gingival collar is formed, the healing abutment is removed and the impression coping is attached. Now for the full mouth impression technique, we need to prepare a custom tray first. So for making a custom tray, before transfer coping is attached to the implant surface and alginate impression is made. Now this transfer impression coping is attached to the lab analog, and this transfer impression coping is again placed back into the coping indentation. Now after attaching the impression coping with the impression is poured. Now once the cast is formed, the transfer impression coping is removed and the final pickup impression coping is attached onto the cast. Now the undercut which is present on the cast is blocked with the help of wax. The wax is adapted all over the surface of the pickup impression coping, and the custom tray is fabricated around the wax. Now once the custom tray is formed, the area of the orifices is widened with the help of burr, and this tray is tried in the patient's mouth. Now, after placing the pickup impression coping in the patient's mouth, the tray is tried and the light body putty impression is made, or a polyether impression can be made. Now, after making the impression, the lab analog is attached to the pickup impression coping, and the impression is poured and the cast is obtained. Similarly, for the implant overdenture case, the same technique can be carried out. First, we need to make an alginate impression. After making an alginate impression, the custom tray can be prepared. The area over which the attachment is present can be trimmed. And at the final step, the pickup impression coping is attached and the tray is tried in the patient mouth. Once the water molding is done, a putty light body or a medium body polyether impression can be made. Now coming to the digital impression, more recently, one of the major development in the implant prosthodontic has been adoption of engineering principle in the form of computer-aided design and computer-aided manufacturing. So CAD/CAM to construct the implant prosthesis. This technology utilizes 3D intraoral scanner, which can alter the way of making impression. Now here, what we do generally, we have scannable impression coping. Now this scannable impression coping are like snap-on impression coping. We need to attach this impression coping onto the implant fixture, and a different intraoral scanner can be used to scan this impression coping. Once these data is transferred to the PC, the position and the actual position of the implant can be determined. Several studies has concluded that when we have to replace the when we have to restore the implant with a single crown, when we have to restore with a single crown, the accuracy is comparable to that of the conventional impression technique. But in case of full mouth rehabilitation, because of the linear deviation is more in the digital impression, the conventional technique is better when compared to that of digital. Now coming to the newer concept, that is on-TM concept. Now generally what happened after placing the healing abutment, at the time of impression making, we remove healing abutment from the implant orifices. But the Nobel Biocare has come with a different option of making impression. Now they have divided this healing abutment into two parts. The first is the basic part, in which the prosthetic platform is seen, over which we can fix the impression coping. Once the soft tissue is healed around the healing abutment, we can either remove the healing abutment from the implant, or we can either remove only the top surface of the healing abutment. So the disadvantage of removing the entire healing abutment, there will be ingression of the microorganism, which will lead to bone loss around the implant. So this technique, the advantage being we are removing only the upper portion of the healing abutment. Now after removing the upper portion of the healing abutment, the intact surface, there is no micro leakage seen. Only the thing is we need to attach an impression coping over the healing abutment and we can make the impression. Now coming to the impression for the preparable abutment, as I have already spoken about it, it comes under the implant, it comes on the abutment level impression, that is direct technique. Now this preparable abutment is attached to the implant fixture and it is torqued. Now after checking the proper seating of this preparable abutment, these are prepared intraorally in the patient mouth. It comes in the variety of material like zirconia, soft peak, and this can be trimmed inside the patient mouth, and the tooth preparation, like in tooth preparation, and the cutting is made. Now after the cutting is made, the impression is made, and in the same fashion how we make a fixed partial denture, this bridge can be made. Now coming to the conclusion, measurable distortion result from the transfer of implant position as recorded with the various impression technique. The magnitude of the distortion was similar with the technique evaluated. In addition to the dimensional changes in the material used, positional error were also attributed to the mechanical component used in the transfer process. The objective is to achieve the passively fitting prosthesis. Further work is indicated to isolate the technique that will reliably and predictably reproduce the intraoral relationship of implant fixture. These are the references. Thank you, sir.